Beyond Well. I'm Sheila Hamilton, and I'm joined by Dr. Rebecca Miller, a psychologist and assistant professor at the Yale School of Medicine, Department of Psychiatry. Hello, Rebecca. It's so nice to talk with you.
Hi, so nice to speak with you as well.
You're serving as director of peer support at Connecticut Mental Health Center in New Haven. And I want you to just describe, if you would, sort of what is the population base of New Haven and the varying types of people with mental illness that you're actually supporting.
Sure. So I work with the Connecticut Mental Health Center, and we are the safety net provider in the local area, in the New Haven area. So we serve folks who have schizophrenia, bipolar disorder, and other serious mental illnesses that impact their functioning, and those who have no insurance or are underinsured. And so we provide a whole range of services from clinical support to employment support, social services, trying to connect people with medical and physical care. We actually have a co-located primary care clinic on site, and then also peer support is part of that mix. So that's my role. We have a diverse community in New Haven, and we serve, our population is probably 40% African American, 20% Hispanic, and then white. And we have a large refugee population actually here in New Haven.
Wow. How many people that you serve are already in poverty?
Oh, I would say the rates of employment are probably 20%. 20% of folks are employed, and so most people are living in poverty, are receiving Social Security benefits and food stamps. So a lot of folks in very dire need, and sort of the interaction effect of mental illness, but then also just social conditions of racism, sexism, having experienced and not a great education system.
Yeah.
And also the effects of trauma. So all of those kind of come together.
Dr. Miller, I've always wanted to ask this question of someone like yourself who sees this kind of desperation and the really dire circumstances of mental illness on people, how you keep your spirits up.
I think that people are people, for one, and also they're such great, I work with such great colleagues, and then also just having the opportunity to learn from folks who receive services here. So many people have been through so much and continue on and continue getting up each day, and then also I identify as a person with mental illness as well, so it's sort of a calling to help others who experience that. And, yeah.
So I want to talk a little bit about your lived experience and why you decided to channel your own recovery into working with other people. At what age did you begin to struggle psychologically?
So I first had symptoms in high school. I would say I had some depression that didn't affect me too badly, but then left for college and then really had a very rough time, becoming more and more depressed and experiencing suicidal thoughts, and ended up taking a year off from college and working in Boston, and ended up being hospitalized for psychosis in that early fall. So it was, and I was told when I was diagnosed that, you must avoid stress, and, these are medications that you'll need to be on for the rest of your life. So I did neither of those. I followed neither of those directions.
Wow. Can you talk about what direction you did follow to be able to, because, for people that are only hearing this, and it'd be great if we had like a video running so that they could see you, but you're a professional, you have a full-time job, you're helping people, you have a beautiful family, like talk about what it was that you did that was not the traditional route of giving up on a life.
I think I've always wanted to write an article about being stubborn and how important that can be in recovery.
That's awesome.
And that, not accepting that. And for me, it really meant that I wanted to find out, well, what was this thing that happened to me? So even during my first hospitalization, when I had the privileges to leave the ward, I went to the library on the campus there and started reading about what I'd been diagnosed with and trying to figure out what had happened and understand the influence of social factors and trauma and early childhood experiences and, really get a sense of what had happened to me. And then from there, I'd always been someone who looked to help others. That was sort of service was something that was promoted in my family. And so, when I was able to make it back to college and graduate and continue on and actually get my PhD, that really was very important to me to be able to get back. And then finally, it took me a long, long time, though, to actually share my own experience with, in a public way. So after I had my daughter, she's now 7, I was diagnosed with early onset Parkinson's disease. And so that really became a point of clarity for me that, I really felt like, what the heck?
Yeah, right. Yeah.
I'm just going to be open about all of it. There isn't time to really waste, agonizing over this.
It's fascinating to me that one disease can present so externally and the other so internally. And people who have Parkinson's are given all kinds of sympathy and support and love and help, and people with mental illness are shunned and given very few resources in our community. I think that having to go through both must be a fascinating sort of social experiment, really.
Oh, yeah. I mean, when I was diagnosed with Parkinson's, my doctor said, "You look like you're getting upset," because I was just sitting across the room, starting to tear up. And I said, "Yes." And he said, "Don't let your disease take charge of you. Take charge of your disease." And I was like, "Oh, okay." And he then recommended this conference that I subsequently went to called the World Parkinson's Congress, which is this fantastic meeting of scientists and doctors and physical therapists and people with Parkinson's and friends and family, where they all come together and kind of meet. And that was just life-changing for me. But I reflect back on how there wasn't anything like that when I was diagnosed with mental illness.
Oh, yeah.
It was vastly different.
It's also fascinating to me that and this is just a great conversation to be able to compare the difference when people are diagnosed with something like Parkinson's or some other disease. They're like, concentrate on your life, enjoy your life, keep your goals up, explore relationships, go hike, and people with mental illness, change your life, quit your job, you need to give up all of the things that are causing you stress. Well, it's often the things that cause people stress are also what causes them great enjoyment, So it's fascinating, just the difference in that. I'm very interested in when talking with somebody who has gone through such a horrendous experience as psychosis about the things that you felt really brought you back to the person that you've become. What was most helpful?
So when I was first in the hospital, I had a very stoic doctor, but I had another guy who was hospitalized, and he said to me, "Hey, do you want to take a shower or something?" And I said, "Oh, that's an interesting idea." And so really, the power of peer support really started there for me.
Wow.
And having, friends who I could talk to. And I think, my own individual pursuits like drawing and writing were really helpful in kind of bringing me back to myself and reconnecting with myself. Because I think one of the things about mental illness, or however you want to describe it, is that you lose trust in your own mind.
Yeah.
Like your mind has kind of wandered off without you.
Uh-huh.
And just the ability to kind of understand your own mind and start to trust that, you can manage what comes up. So for a long time I struggled with, if I started to feel really good or I started to feel really bad, thinking, oh, are these symptoms? Keeping a very...
Right, rather than just being human.
Right, exactly.
Right.
Took me a while to relearn that and say, no, this is, I'm having a lot of fun. Like, that's okay.
Yeah, it's all right to be joyful. What about some of the experiential approaches that you're sharing with people now in your clinical training? Are you actively helping patients deprescribe, have a lighter psychopharmaceutical load?
So I'm not specifically doing that myself. I work with colleagues who are actively working with people to deprescribe. I consult on the more psychosocial aspect of it. And then I am also working with colleagues to work with trainees, so residents, psychiatry residents, and psychology interns on better understanding what it's like to actually be, in a psychiatric hospital. So we're working on a protocol that's basically a guided visualization. So instead of, usually guided visualizations are like in the forest or at the beach, but this one is taking you to an inpatient unit.
Oh my gosh, how wonderful. Yeah.
So really to try and give people just somewhat of a sense of what it might be like and what it could be like for the people that they're working with, because I think oftentimes we become desensitized or we don't even realize how scary those kind of first experiences of walking onto a unit or not knowing what's going on, and combined with being, very emotionally distressed as well.
Yeah.
So really, how can we, help educate people about that? We had come up with an idea of having people actually live on an inpatient unit for 3 days. But we haven't quite worked out the logistics of how that would actually happen.
One of the things that I notice, and my late husband is the reason that I'm so fascinated with this field of work, and he was hospitalized and the nurses worked behind bulletproof glass, and they actually didn't really know his name, and he only saw his prescribing doctor for 15 minutes a day. And I thought, if that were to occur in, for instance, the treatment of Parkinson's, in the treatment of diabetes, in the treatment of any other sort of complex disease process or complex disorder process, people would be so outraged. Why is it okay that people with mental illness are treated this way?
Yeah, I mean, I think that, one, there's a question that I always have about why we have specific hospitals for psychiatric versus medical conditions.
Yeah.
And that separation is sort of a strange one in some ways, and that we, oftentimes people who are hospitalized for psychiatric reasons are struggling with interpersonal relationships in some sort of way.
Yeah.
Or struggling with their relationship with themselves. And then we put them all together and we ask them to go to groups,
Yeah.
And that just seems like it's a kind of leftover model that we haven't necessarily questioned or kind of looked at seriously. I don't know of randomized clinical trials that, test inpatient hospitalization versus another treatment. But we do know that there's evidence that being hospitalized psychiatrically increases your risk of later dying by suicide, dying by cardiovascular problems.
Yeah.
So and that many people experience trauma in the hospital.
It's what's fascinating to me is, for instance, a person who has their first psychosis because they're smoking pot at 21 might be put into a psychiatric ward with chronically ill people with schizophrenia, long-term problems, and completely lose any hope about their potential of recovery based on just what they're seeing around them, and that they might be sharing the same diagnosis,
Right.
That's always seemed very counterintuitive to me.
Right, like this is what it means to be a mental patient.
Right.
And
Yeah.
yeah, no, I think we need to really think of new models. There are groups out there that are actually receiving a lot of support lately from federal organizations about increasing the number of hospital beds. And I don't disagree that we need better treatment options for people. There are way too many people who end up in prison, and that's not okay. But I also think we need to be creative and think about new kinds of solutions and new models to support people.
Yeah. It does occur to me that many times the hospital itself serves as an offload for the family who is just at the breaking point of not being able to take either the psychological stress or the financial stress or the lack of sleep that can come when someone is that ill, and that that hospitals do serve a place as the emergency room especially for families who can also be at risk.
Yeah, for sure. But I think there are also things like peer-run respites that serve the purpose of providing another place for the person to stay, providing a break for the family, and more support for the person, but not the same kind of institution that is a hospital. They're also, I think it's in the Netherlands, they have like a family placement that you can, it's sort of like a family agrees to take in someone, sort of foster a person for a while to support them through a more difficult time. So just thinking about like these other possible models instead of just this kind of false dichotomy of either a hospital bed or, on your own in your home.
Wow. That's Dr. Rebecca Miller, psychologist and assistant professor at the Yale School of Medicine, Department of Psychiatry. Thank you again, Rebecca.
Thanks. Have a great day.
And if you want to find out more about this topic or Rebecca's work, you can go to the Foundation for Excellence in Mental Health Care or just click the link below.